This training discusses the prevention of waste, fraud, and abuse, specifically in the billing for services that are provided. The training includes watching the video below and also completing the Medicare Waste, Fraud, and Abuse training online. There is an attachment in the lesson media that will provide information on how to enroll and complete the online course. To successfully complete this lesson, you must submit your completion certificate for the online course to the lesson teacher. There is one excellent handout for you to download and review, and there is a copy of the PowerPoint slides for this presentation. After you have completed all aspects of this lesson, you are required to complete the attached quiz with a passing score of at least 70% in order to complete this lesson. Waste is defined as the thoughtless or careless expenditure, mismanagement, or abuse of resources to the detriment of the U.S. government. Waste also includes incurring unnecessary costs resulting from inefficient or ineffective practices, systems, or control. An example of waste might be ordering excessive diagnostic tests for the individual where there may be clinical justification, but the test is not actually needed. Abuse describes practices that may directly or indirectly result in unnecessary costs to the Medicare program. Abuse includes any practice that does not provide patients with medically necessary services or meet professionally recognized standards of care. The difference between fraud and abuse depends on specific facts, circumstances, intent, and knowledge. Examples of abuse include billing for unnecessary medical services, charging excessively for services or supplies, or misusing codes on a claim, such as upcoding or unbundling codes. Upcoding is when a provider assigns an inaccurate billing code to a medical procedure or treatment to increase reimbursement. Medicare abuse can also expose providers to criminal and civil liability. Fraud typically includes any of the following: knowingly submitting or causing to be submitted false claims or making misrepresentation of fact to obtain a federal health care payment for which no entitlement would otherwise exist. Knowingly soliciting, receiving, offering, or paying remunerations, for example, kickbacks, bribes, or rebates, to induce or reward referrals for items or services reimbursed by federal health care programs, and making prohibited referrals for certain designated health services. Anyone can commit health care fraud. Fraud schemes range from solo ventures to widespread activities by an institution or group. Even organized crime groups infiltrate the Medicare program and operate as Medicare providers and suppliers. Examples of Medicare fraud include knowingly billing for services at a level of complexity higher than services actually provided or documented in the medical record, knowingly billing for services not furnished, supplies not provided, or both, including falsifying records to show delivery of such items, knowingly ordering medically unnecessary items or services for patients, paying for referrals of federal health care program beneficiaries, and billing Medicare for appointments patients fail to keep. Defrauding the federal government and its programs is illegal. Committing fraud exposes individuals or entities to potential criminal, civil, and administrative liability and may lead to imprisonment, fines, and penalties. Criminal and civil penalties for fraud reflect the serious harms associated with healthcare fraud and the need for aggressive and appropriate intervention. Providers and healthcare organizations involved in healthcare fraud risk being excluded from participating in all federal healthcare programs and losing their professional licenses. There are a number of federal laws that govern healthcare fraud and abuse. We will discuss each of these laws individually on the following slides. The laws include the False Claims Act, the Anti-Kickback Statute, the Physician Self-Referral Law, also known as the Stark Law, and items in the United States Criminal Code. The Federal Civil False Claims Act, found in United States Code sections 3729 to 3733, protects the federal government from being overcharged or sold substandard goods or services. The Civil False Claims Act imposes civil liability on any person who knowingly submits or causes the submission of a false or fraudulent claim to the federal government. The terms knowing and knowingly mean a person has actual knowledge of the information or acts in deliberate ignorance or reckless disregard of the truth or falsity of the information related to the claim. No specific intent to defraud is required to violate the Civil False Claims Act. For example, a physician knowingly submits claims to Medicare for medical services not provided or for a higher level of medical services than actually provided. The penalties for violation of the False Claims Act are civil penalties, which may include recovery of up to 3 times the amount of damages sustained by the government as a result of the false claims, plus penalties up to nearly $23,000 per false claim filed. Additionally, under the Criminal False Claims Act, found in U.S. Code Section 287, individuals or entities may face criminal penalties for submitting false, fictitious, or fraudulent claims, including fines, imprisonment, or both. The Anti-Kickback Statute, found in U.S. Code Section 1320A through 7BB, makes it a crime to knowingly and willfully offer, pay, solicit, or receive any remuneration, directly or indirectly, to induce or reward patient referrals or the generation of business involving any item or service reimbursable by a federal healthcare program. When a provider offers, pays, solicits, or receives unlawful remuneration, the provider violates the Anti-Kickback Statute. Remuneration includes anything of value, such as cash, free rent, expensive hotel stays and meals, and excessive compensation for medical directorships or consultancies. For example, if a provider receives cash or below fair market value rent for medical office space in exchange for referrals. The criminal penalties and administrative sanctions for violating the Anti-Kickback Statute may include fines, imprisonment, and exclusion from participation in the federal health care program. Under the CMPL, penalties for violating the Anti-Kickback Statute may include 3 times the amount of the kickback, plus up to $100,000 in fines per kickback. The Safe Harbor regulations, found in the Federal Regulations Section 1001.952, describe various payment and business practices that, although they potentially implicate the Anti-Kickback Statute, are not treated as offenses under the Anti-Kickback Statute if they meet certain requirements specified in the regulations. Individuals and entities remain responsible for complying with all other laws, regulations, and guidance that apply to their businesses. The Physician Self-Referral Law, found in U.S. Code Section 1395NN, often called the Stark Law, prohibits a physician from referring patients to receive designated health services payable by Medicare or Medicaid to an entity with which the provider or a member of the provider's immediate family has a financial relationship, unless an exception applies. For example, a provider refers a beneficiary for a designated health service to a clinic where the provider has an investment interest. Penalties for providers who violate the Stark Law may include civil monetary penalties up to $24,478 for each service, repayment of the claims, and potential exclusion from participation in the federal health care programs. The Criminal Health Care Fraud Statute, found in U.S. Code Section 1347, prohibits knowingly and willfully executing or attempting to execute a scheme or lie in connection with the delivery of or payment for healthcare benefits, items, or services to either defraud any healthcare benefit program or to obtain by means of false and fraudulent pretenses, representations, or promises any of the money or property owned by or under the control of any healthcare benefit program. For example, several doctors and medical clinics conspire in a coordinated scheme to defraud the Medicare program by submitting medically unnecessary claims for power wheelchairs. The penalties for violating the Criminal Health Care Fraud Statute may include fines, imprisonment, or both. The exclusion statute, found in United States Code Section 1320A through 7, requires the Office of the Inspector General to exclude individuals and entities convicted of any of the following offenses from participation in all federal health care programs. The offenses include Medicare or Medicaid fraud, as well as any other offenses related to the delivery of items or services under Medicare or Medicaid, patient abuse or neglect, felony convictions for other health care related fraud, theft, or other financial misconduct, and felony convictions for unlawful manufacture, distribution, prescription, or dispensing of controlled substances. The Office of the Inspector General may impose permissive exclusions on other grounds, including misdemeanor convictions related to healthcare fraud other than Medicare or Medicaid fraud, or misdemeanor convictions for unlawfully manufacturing, distributing, prescribing, or dispensing of controlled substances. Suspension, revocation, or surrender of a license to provide health care for reasons bearing on professional competence, professional performance, or financial integrity. Providing unnecessary or substandard services, submitting false or fraudulent claims to a federal health care program, engaging in unlawful kickback arrangements, or defaulting on health education loans or scholarship obligations. Excluded providers may not participate in the federal health care programs for a designated period. If the individual is excluded by the Office of the Inspector General, then federal health care programs, including Medicare and Medicaid, will not pay for items or services that the provider furnishes, orders, or prescribed. Excluded providers may not bill directly for treating Medicare and Medicare patients, and an employer or a group practice may not bill for an excluded provider's services. At the end of an exclusion period, an excluded provider must seek reinstatement. Reinstatement is not automatic. The Office of the Inspector General maintains a list of excluded parties called the List of Excluded Individuals or Entities. The Civil Monetary Penalties Law, found in U.S. Code Section 1320A through 7A, authorizes the Office of the Inspector General to seek civil monetary penalties and sometimes exclusion for a variety of healthcare fraud violations. Different amounts of penalties and assessments apply based on the type of the violation. Civil monetary penalties also may include an assessment of up to 3 times the amount claimed for each item or service, and up to 3 times the amount of remuneration offered, paid, solicited, or received. Violations that may justify civil monetary penalties include presenting a claim that is known or should be known is for an item or service that was not provided as claimed, or that is false or fraudulent, violating the anti-kickback statute, and making false statements or misrepresentations on applications or contracts to participate in the federal health care programs. The final step in preventing waste, fraud, and abuse is that any organization that bills federal health plans must have a corporate compliance plan. The Office of the Inspector General has declared that there are 7 fundamental elements of an effective compliance plan. These elements are meant to guide providers and organizations in the process of developing well-defined plans and strategies for their own compliance programs. The 7 fundamental elements are implementing written policies, procedures, and standards of conduct, designating a compliance officer and compliance committee to provide program oversight, using due diligence in the delegation of authority, educating employees and developing effective lines of communication, conducting internal monitoring and auditing, enforcing standards through well-publicized disciplinary guidelines, and responding promptly to detected offenses and undertaking corrective actions. Each of the elements will be discussed in greater detail in the subsequent slides. An effective compliance program is dependent on written policies, procedures, and standards of conduct. These documents memorialize the practice's expectations with regard to corporate compliance. Further, they explain the practice's commitment to legal standards, ethical conduct, and quality care. Each healthcare practice's compliance policies should include a code of conduct that defines the organizational mission, values, expectations, and guiding principles for workplace behavior. A code of conduct identifies model behavior for employees and explains how to report suspected incidences of compliance violations or unethical activity. The designated compliance officer and compliance committee should be involved in developing the policies, which should specifically delineate their respective duties. Once developed, compliance policies and procedures should be reviewed with and distributed to all employees of the organizations. The review should occur within 90 days of hire and at least annually, and employees should be asked to acknowledge their review and understanding of the policies. Additionally, each organization should have guidelines for periodic review and updating of the compliance policies. As part of the second element, each healthcare provider should designate two key roles, the compliance officer and the compliance committee, and assign duties to their respective roles. The compliance officer should report directly to the CEO or senior management and should have primary responsibility for the compliance program structure and administration. The compliance officer should be very familiar with the organization's operational and compliance activities. This point is crucial because a compliance officer without any delegated authority will likely not be very effective. The compliance officer's daily duties might include understanding and administering the compliance program, being informed about the outcomes of audits and monitoring activities, reporting on compliance enforcement activities, and assessing and reviewing the compliance program. The compliance officer might have other clinical and administrative duties aside from compliance duties. The compliance committee is a multidisciplinary committee that reports directly to the CEO or other high-ranking person or people within the organization. The compliance officer and compliance committee are jointly responsible for certain duties related to administering the compliance program. These responsibilities include developing, reviewing, and updating compliance policies and procedures, developing and auditing the work plan and the risk assessment plan, attending meetings for operational staff, monitoring and auditing compliance performance, enforcing compliance program requirements at all levels of the organization, recommending policy, procedure, and process improvements, and finally, enforcing disciplinary standards. The third element of an effective compliance plan requires that each organization's management team take responsibility for and engages in proper due diligence in the hiring and periodic assessment of management employees. This element implies that organizational leaders should conduct thorough background checks on all new management employees and periodic background checks on existing management employees. The practice should undertake reasonable efforts to ensure that employees have not engaged in illegal activities or other conduct that is inconsistent with the practice's compliance and ethics programs. Further, the practice's management team should ensure due diligence when hiring or contracting with vendors or other organizations. The fourth core element of an effective compliance program is training and education to ensure adequate understanding of the expectations set forth in the compliance plan and code of conduct. Compliance training should be mandatory for all employees. The initial training should be a comprehensive review of the compliance plan and code of conduct. Thereafter, an annual review training should occur that highlights any compliance program changes or new developments, as well as re-emphasizes the practice's code of conduct. To aid in information retention, training programs should be interactive and include actual compliance scenarios that employees and managers might encounter. Additionally, the compliance officer should communicate compliance messages via other informal training methods such as posters, newsletters, and internet communication. The fourth element also includes developing effective lines of communication, which involves making communication about compliance issues an integral part of the practice and having an open door policy throughout the organization. Recommendations for developing an effective open communication culture include the following: ensuring communication channels foster dialogue rather than one-way communication, educating employees about the importance of reporting issues in a timely manner, developing a formal process for managers to communicate compliance issues and results to staff, and creating an anonymous reporting process to prevent real or perceived retaliation, for example, an anonymous hotline, a drop box, or a well-promoted open-door policy. Employees should have several ways to report compliance and ethical concerns. The compliance officer or the compliance committee should evaluate the reporting process for effectiveness. Questions to consider include: are the employees familiar with the compliance ethical issues they should report? Are employees aware of the reporting process and to whom they should report concerns? Are employees aware of the specified time frames for reporting compliance and ethical issues? Furthermore, employees should feel comfortable reporting issues to multiple individuals within the organization. The compliance officer should be available and accessible for routine questions about compliance or ethics. The fifth element of an effective compliance program is creating a system for monitoring and auditing the effectiveness of the program. This system will help organizations comply with the CMS requirements and identify compliance risks. Monitoring may include reviewing procedures to gauge whether they are working as intended and following up on recommendations and corrective action plans to ensure that they've been implemented. Monitoring should occur on a regular basis, such as weekly or monthly. Auditing is a comprehensive review and requires more effort than monitoring. Auditing ensures compliance with statutory and CMS requirements and includes routine evaluations of the compliance program to determine the program's overall effectiveness. Internal staff or an external contractor should conduct an audit at least annually. The audit should result in a written report of findings and recommendations that the compliance officer or compliance committee should follow up on as part of their responsibilities. Conducting a formal baseline risk assessment is a crucial component of developing monitoring and auditing work plans. The risk assessment should include areas of concern identified by CMS and other authoritative organizations, as well as classification of risk levels. Areas identified as high risk, such as coding and billing, working with excluded providers, should be audited more frequently. The monitoring plan should cover the frequency of monitoring, the persons responsible, and the issue of concern for the organization. The auditing work plan should cover methods the organization will use to conduct internal investigation, a time limit for closing investigations, corrective action plan guidelines, and criteria for external independent contractor review and/or referral to CMS or the Office of the Inspector General. The sixth element of an effective compliance program is to ensure consistent and timely discipline when an investigation confirms a violation. Disciplinary guidelines must be clearly written and describe the expectations and consequences for noncompliance. Guidelines should include sanctions for failure to comply with the Code of Conduct, failure to detect noncompliance when routine observation or due diligence would have provided notice, and failure to report actual or suspected noncompliance. The practice should review disciplinary guidelines at least annually with all employees, and the information should be readily available for for review so that employees are well aware of their obligations. The final element of an effective compliance program is the use of corrective actions when vulnerabilities, non-compliance, or potential violations are identified. Examples of corrective action include staff education or re-education, repayment of any overpayments, and finally disciplinary action against the responsible employees. Healthcare compliance and preventing waste, fraud, and abuse is a complex topic that involves numerous regulations and layers of oversight. However, at its core, compliance is intended to promote ethical conduct and business practices. By developing and adhering to an effective plan and educating staff, organizations can prevent fraudulent activity, promote ethical behavior and business practices, and support quality of care. This completes our training on preventing waste, fraud, and abuse. As a part of this lesson, you must also complete the CMS Waste, Fraud, and Abuse training online and submit your completion certificate to the lesson teacher. There is one excellent handout to download and review, and there is a copy of these PowerPoint slides. When you are completely comfortable with all of the material, you must complete the attached quiz with a passing score of at least 70% in order to complete this lesson. Thank you and good luck.